Hello, I'm Dr. Maury Markman from City of Hope, and I'd like to end this discussion we've had for the last several sessions on clinical issues ethical issues in clinical research by giving an example that I experienced in my time as a clinical investigator and clinician in the gynecologic oncology arena, and one of which I actually wrote about in a piece in the Journal of Clinical Oncology a number of years ago. Let me set the scene for you. Pegylated liposomal doxorubicin was approved by the FDA for the treatment of platinum-resistant ovarian cancer. This was obviously many years ago. The drug was approved by the FDA at a dose of 50 milligrams per meter squared, delivered every 4 weeks. Objective response rate of approximately 20-25% in this setting. Randomized controlled trials led to the drug's approval. That's history is not important, except that it was FDA approved for this purpose. However, about a quarter of the patients who participated in these studies, in the data, experienced symptomatic stomatitis or hand-foot syndrome, well recognized to be a complication of the drug. As a result, as soon as the drug was approved, clinical investigators do what they do. It tried to examine or explored the use of a lower dose of the drug, both from the point of view of efficacy and what would do to the toxicity. Turned out with, again, tremendous amount of literature here, prior publication, multiple publications demonstrated, including randomized controlled trials, demonstrated that a dose of 40 milligrams per meter squared delivered every 4 weeks in this palliative care setting, palliative treatment setting, resulted in a similar objective response rate, time to disease progression, but with a substantial lowering of the risk of hand-foot syndrome and stomatitis. However, the pharmaceutical company that was responsible for this drug, although they were certainly delighted people using the drug, had no responsibility to go back to the FDA and ask for a change in the labeling. They certainly had no responsibility to go back and do whatever the FDA said in terms of required trial. Doctors in the community were using 40 milligrams per meter squared. That was perfectly fine. That's the practice of medicine. However, subsequently conducted phase 3 randomized trials looking at other agents that were coming along to potentially get FDA approval, needed a control arm for their studies. And they used, logically, pegylated liposomal doxorubicin, which was FDA approved for that purpose as a control arm. However, the dose of the drug administered in several of these regulatory studies was 50 milligrams per meter squared, given every 4 weeks, because that was the approval. Now, I, of course, am not aware of whether the FDA mandated that dose. I don't know if the companies tried to suggest using a lower dose. Of course, I'd have no way of knowing. What I do know is the patients who are going to be on those studies, who will be assigned to the control arm, randomized, would be getting a drug at a dose which was almost certainly not being used in actual clinical practice by the same doctors who are participating in this trial. So patient A came in, not on the study, might get pegylated liposomal doxorubicin, almost certainly at a dose of 40 milligrams per meter squared at that point. But if they were randomized to go on this study and they got pegylated liposomal doxorubicin, they'd be getting a higher dose, a more toxic dose. And the question is, I think you get the point, were the patients informed by the doctors that they would be getting a higher dose? Were they informed that the doctors would have used a lower dose if they weren't on the trial because of the toxicity? And if they weren't informed, why not? Fundamentally, why not? And the answer is what? I'm a clinical investigator and I put people on study. I challenge that. So I don't know the answer to the question. All I know is these studies were done. That era is past. If one were to use pegylated liposomal doxorubicin today, I certainly would use a lower dose. But it's, again, the question is, what was the obligation of the individual physician caring for her or his patient to inform them of the justification or lack thereof of the control arm on the study to which they were being asked to participate? Final point I will ask to highlight the fact that these ethical issues remain. We are in an era of rapidly expanding knowledge, rapid developments in new therapies. This is incredibly good for our patients. However, the speed at which standard of care is changing and novel drugs are changing is faster in many cases than the conduct of the studies that we are currently participating in. So here is the scenario. Randomized phase 3 trial was started a year ago. A particular regimen was started, perfectly reasonable. The control arm was drug X. But 2 months ago, a phase 3 trial, randomized trial was completed. New drug was approved that had better outcome for a very similar setting than the control arm of the study that you are participating in. Are you still going to put patients or ask patients to participate in the randomized controlled trial that is ongoing at your institution, which has a control arm which is inferior based on the data available to you to the now standard of care drug that's available off the study? Obviously, if you offer the patient this new standard of care drug, they won't go on a trial. What is your obligation? To me, it's clear. You give the patient the best therapy available for them, regardless of what study you might have open at your institution. Now, I don't have an answer to what the FDA and companies do in these situations about studies. You can't simply change the study in the middle. But the responsibility of the treating physician, the patient's physician, is not to the FDA, is not to the studies participating in. It's to the patient they are caring for. And I thank you for your attention.